Good afternoon, everybody. Thank you so much for joining today, the Hypertension Bundle Team webinar. We're really excited today. We've got two wonderful speakers in Dr. Peter Bernstein and Kelly Goff, who are going to present in just a few minutes. So remind everybody, just please keep your phone on mute if you're not talking, and use the chat box. We love the questions and need the questions. So we'll go ahead and get started. Terrell, if you'll go ahead and start us off, the next slide. We are working on implementing the AIM obstetric hemorrhage bundle, and all of the elements included. We have 44 hospitals who hope many of them are on this webinar today, but are all working really hard to implement all the elements of the bundle. Next slide. Just to kind of highlight the hemorrhage driver diagram with our SMART aim to reduce severe maternal morbidity in women who have a hemorrhage by 20% by the end of 2020. So next slide. And the goals, 20% reduction in severe maternal morbidity, and then also 100% increase is some really important measures. Increase risk assessment by 100%, debriefs on all cases of hemorrhage by 100%, and also a process in place for quantified blood loss. Okay, so next slide. I want to briefly go through just the hemorrhage and structure measures. So for the structure measures for hemorrhage, we haven't had any changes since our last webinar, so I'll move on to the next slide. But for process measures, we did add at this last data template sheet that went out for July through September that was sent out in October, and you're reporting on, hopefully many of you reported on it already at the end of October. But there is a measure for those of you who may not be aware already under P2, provider education, and P3, nursing education, that in addition to education on OB hemorrhage and the OB hemorrhage bundle, that there is also a measure for staff training for implicit bias. Next slide. And the same thing kind of with the report changes. Let me go back first though to why that was added. Remember, the reason that we selected the bundles that we're working on as kind of a top priority for the maternal initiatives under GaPQC is because of hemorrhage and hypertension are two of the leading causes of maternal death kind of consistently for the years that we have completed case review. And the other thing is that there is a significant disparity in the state associated with maternal death. So while implicit bias is a tool and it will be part of our initiatives, a very small starting point, we have included plans to include health equity and the health equity focus in all of the work of the collaborative, as we absolutely need to do. So there'll be more information to come, but just for this first step, adding the measure for implicit bias training is very important. And you'll see this on the report form here under P2 and P3 under provider and nursing education. You'll also see a note on the side and comments that while this is on here, because it needs to be for planning purposes, it's not something that you'll actually report on until the end of the first quarter of calendar year 2020. So it will be for the period January through March, and so it will go on to the report you submit at the end of April. I will say, we already had some hospitals reach out to ask what kind of resources we're going to provide or what's available or how to get started. Just please know that there's going to be more information that we're going to share. And we do expect in the beginning that in a large number of facilities, this is likely to be a very low baseline number. And in some cases, there may not be anything in place at this time. But all the more important, we'll see change as we move over time, and more of you implement processes and share, and we can learn from each other and kind of take health equity, even further into the work that we're going to be doing once we get outside even of hospital work. Next slide, please. So just to kind of get some resource information started, there was a group that was formed as a health equity subcommittee for a year, and now during that time, they've just now all of their work is being incorporated, like I just mentioned, within the whole collaborative and all of the initiatives. But during the time the group was together, they made some great recommendations for how we could maybe take these first steps, implement some training and assessment, policy development, that kind of thing. And so just to kind of get everybody thinking about what can you do and where should you start, just kind of go back for now and review your information and review information that's available about implicit bias. There is a lot of really great resources out there. Also look internally, talk with your team, bring in some new team members if you need to begin this planning process and evaluation of your next steps. One of the first resources listed is a fairly well-known tool, and it's a implicit association test done through Harvard. It's a free test. The link is there. It's certainly something that you can explore, as well as some others. Just to get you thinking, to get your team talking. It may be something you want that tool or something similar that you want to share out to other parts of your team. And just to kind of let you know, we are also being proactive and looking at what we can do to bring more training resources into Georgia and how we're going to make them available. We started out, the Health Equity Group recommended a resource to the Association of Medical Schools because they had done a good bit of training. Their contract with the vendor is currently not active, that they had used and were very pleased with, but they did refer me directly to the vendor, and that's Cook Ross that you see listed. We're not sure exactly what we're going to have yet. This is just some initial planning, looking at costs, what's available. Please share additional resources that you know of. On the hypertension call that ended shortly, a short time ago, we had a team member who offered some other additional resources. So please, you can speak up and add those in, type them in the chat box, email us or call us later. We'll be glad to have that. But we are considering one approach is to have kind of a keynote presentation from the company at our annual meeting in April, and then followed by resources for online training and bring in some train-the-trainer courses into Georgia to make available to hospital staff. So just keep in mind that's what we're planning. You'll hear more on the next webinar, in addition to, and also future webinars as we move through this process and work on it together. It's a great opportunity to really build some important build on the important work we're already doing by incorporating health equity into everything we're doing. So next slide. One last thing, just on the reports were due for the last quarter, October 31st. We were still missing a good many this morning. I think Terrell followed up with most everybody we hadn't received, and we've received some since then, so thank you, those of you that have sent those in today. But if you haven't, please, 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 we really need those by no later than Friday. We have to get those uploaded into the AIM portal and then do a data analysis so we can report back to you at the end of the month and kind of where your hospital stands with everybody else. Okay, thank you. I will go, before I move on, does anybody have any questions now? Again, use the chat box is fine, and okay. Well, without further ado, I don't want to keep our speakers waiting. We so greatly appreciate them being with us today. Really excited to have Dr. Peter Bernstein, who's the professor of OB and gynecology and women's health, and is the maternal fetal medicine division director, Montefiore Medical Center and Albert Einstein College of Medicine. He's the past director of the MFM Fellowship Program there, and did his training in OB-GYN at Yale New Haven Hospital, and his clinical fellowship in maternal fetal medicine at Albert Einstein College of Medicine. Dr. Bernstein also has completed a Master's of Public Health degree at Columbia University. Some of his clinical and research interests concern improving systems of care for women, particularly those who are underserved and have medical complications. His main area of focus has been the development of a comprehensive patient safety program that includes team training, medical stimulation, and systems redesign. Another focus of his has been the implementation and promotion of a revolutionary model of group prenatal care centering pregnancy. He is nationally recognized in the areas of patient safety and quality improvement and in the area of preconception care. As a result of his work locally and nationally, Dr. Bernstein served on the board of the Society of Maternal Fetal Medicine, chaired the American College of Obstetrician and Gynecologists Patient Safety and Quality Improvement Committee, and currently is the chairman of the Council on Patient Safety in Women's Healthcare that has representation of all national professional organizations that focus on women's health. We are beyond thrilled that you could be here with us today, Dr. Bernstein, and so look forward to hearing this presentation. When you initially sent over your slides, I have to tell you we were just so excited about this. We even did share the information with hospitals who aren't currently participating in our initiative just because we didn't want them to miss out on this opportunity. So, thank you.
Well, thank you for having me, and congratulations on the amazing work that you're doing. This is really important stuff, and I hope I can help you out. So I'm going to talk about strategies for improving debriefing. Next slide, please. I have no conflicts of interest to report. Next slide. So what we're going to be talking about is why debriefing is beneficial for improving patient outcomes. We'll talk about some strategies and tactics for holding debriefings and how to make debriefings be more effective. So next slide. Jumping right into it. Debriefing is defined as a brief and informal exchange of and feedback after an event has happened. It's designed to improve teamwork skills and outcomes for the next time you encounter something similar. And the idea is to develop an accurate reconstruction of what happened, analyze why those things happened, and what should or could be done differently next time, and see if you can figure out if there are any systems issues that should be addressed. Next slide. The history of this is that it comes from the military, when individuals returning from a mission would discuss and describe their experiences, both in order to learn from what had happened, in order to improve performance, but also potentially to provide psychological support after traumatic events. And it was adopted by the aviation industry as part of crew resource management in the 1970s as a way to change the culture from one that was extremely hierarchical to one of high reliability and increased safety through collapsing the hierarchy by allowing people who were sort of lower on the totem pole to speak up and share their experiences. Next slide. So, everybody has this slide somewhere. From the Institute of Medicine to Air is Human is a report that they issued in 1999. I also have this slide. I have the book on my bookshelf. I'm looking at it right now. Probably nobody has read the book because it's huge, But the idea was that healthcare organizations should look to other industries for strategies to begin the journey to becoming highly reliable. And those are organizations that have systems in place allowing them to consistently accomplish their goals while avoiding catastrophic errors. And debriefing is a tool to help accomplish that. Next. So debriefing is a key component of Team Steps. And as probably many of you know, Team Steps is an AHRQ program that has these 4 domains of improving communication, situation monitoring, mutual support, and leadership. And they have these very specific tools and strategies to assist members of teams in becoming more effective and highly functional. Debriefing is actually a tool that sits in the leadership bucket, but it also really falls in mutual support and improving communication and helping teams to improve situation monitoring, but it sits in the leadership bucket. Next slide. So this is a famous painting by Thomas Eakins that's at Pennsylvania Hospital in Philadelphia. This is how we used to practice medicine, where the light from the heavens is shining down on the surgeon. Everybody else's face is kind of in the shadows. They're less important. The surgeon is the maestro. He is the person that everyone looks to and is, sort of the messenger from the heavens who's come to solve the problem. This is not what medicine is today. What medicine is today is in the next slide. And that is that medicine is a team event. There is a leader somewhere in this group of folks who are servicing this Formula One racing car, but you can't tell. Everybody has a role, but there is someone conducting things here. Everybody is equally important in some ways. There's a collapse of the hierarchy, although there's still a leader, but there's a recognition that the leader doesn't know everything that's going on and has to rely on team members in order to accomplish what they want to accomplish. And what you need to do, though, is understand the perspectives after an event has happened. You need to understand the perspectives of the other members of the team. Next. So high reliable organizations are safety-oriented. Operations are a team effort. Communication is highly valued and it's rewarded. Emergencies are rehearsed. The unexpected is practiced. Top brass devotes appropriate resources to safety training. Members are always thinking about what can go wrong. Next slide. And there are certain principles that underlie achieving these performance goals. And that is a preoccupation with failure, reluctance to simplify, sensitivity to operations, commitment to resilience, and deference to expertise. And by deference to expertise, that isn't that the surgeon is the expert. That is that each person on the team has an expertise in doing their role, and that the leader doesn't necessarily have that expertise. So, the scrub tech has a certain knowledge of the instruments and where they come from and how to make sure they're cleaned, and the things that the surgeon wouldn't necessarily know but does need to know and needs to recognize, that even the scrub tech or the guy who cleans the equipment recognizes that there's an expertise there that leadership doesn't have. Next slide. So debriefing sits next. Hit the button again. I hope the circle appears. Debriefing sits in the tools and strategies section of the Team Steps tools. It's one piece of the puzzle that you need, one of the tools, and we'll go now into a little bit more depth of specifically around debriefing. Next slide. Debriefing can be a first step to identify critical areas of focus from frontline team members involved in major events, which can guide further review. So it's critical to get information from all members of the team. Next slide. So keys to conducting a good debriefing, and it's a challenge, and it takes skill for the person leading the debriefing, because you want to give everybody the opportunity to speak up. You want to make them comfortable, recognizing that sometimes the events that we're debriefing are emotionally challenging for the team. And on the other hand, you do want to identify areas for opportunity, where there's opportunities for improvement, but in a way that is not going to shut down folks and prevent them from speaking up and sharing what they have to share, because they may have information that you want. So the key elements are that you be empathetic, non-blaming, non-threatening. It should be conversational. When you say pairing advocacy with inquiry, that's a technique that's in the literature where you both are sharing your point of view, but inquiring what others' points of views are as well, so that they feel comfortable speaking up, that you show that you value what they have to say, so that there's no level of intimidation, because you need to recognize that there is a hierarchy and you're trying to collapse it. So you don't want to grill people. You don't want to say, don't you know? Didn't it occur to you? Why didn't you double check that? Or playing a game around sort of guess what I'm thinking. That's going to shut down lines of communication, and there may be information that you want out there. You don't want it swept under the carpet. Next. So you want to be non-judgmental. That's a goal. It may not be possible, but you want to find a way to create psychological safety and be non-confrontational, and yet share constructive criticism. And so this is a real challenge. It takes practice. It's called debriefing with good judgment. It's a mental model. You want to understand the mental model that drove participants' actions, recognizing that everybody typically, almost universally, had good intentions in the care of the patient during the individual event. And so given that they had good intentions, you want to understand why they did what they did, what were the barriers to them accomplishing maybe what you wanted them to accomplish. Was it a knowledge deficit? Was it an equipment failure? Was it a systems issue? And so you need to keep the lines of communication open. You want to adopt this sort of stance that unites unites this environment where you're demonstrating curiosity and respect, and speaking in a way that combines both advocacy, where you're sharing what you want to share, but also requesting input. Next slide. The plus delta technique is one where you say what went well and what could have gone better. Sort of one step further is the sandwich technique, which is sort of the plus delta with a little bit more, where you say what went well, what could have gone better, what are the lessons we've learned for the future, and then finish by reiterating the positives, so that people don't walk away necessarily. If the outcome of the event has been bad, you don't want them to walk away feeling, blown away. Typically, when we do a debriefing, we give everybody a chance, and there's always something that went well. We give everybody a chance to say what went well, and then we give everybody a chance to say what could have gone better, and then people share what their lessons were learned, and the leader reiterates the positives. So who should be involved in the debriefing? Well, it should be an interdisciplinary team. You may want a social worker there for the more severe events, because folks may need emotional support, both the team and maybe the family. You need to decide what events you want to debrief. I've heard of organizations that debrief after every single delivery. My labor floor is too busy for that, so we have certain events that I'll share with you which trigger debriefings. But you need to decide what you want to debrief. When do you want to debrief? Well, you want to do it as close to the event as possible, to maximize the potential for information gathering and identifying systems issues. As you get further from the event, it may be harder to bring all of the people together who were participants in the management of the event. And memories fade, and, rationalizations, and, people start to write the stories for themselves that may not be quite as accurate as if you do it close to when the event happened. Ideally, you want to do it even before, documenting the event, and one of the advantages of doing that is that you sort of make sure everybody's got the full story before they start charting, and you can sort of helpfully avoid discrepancies in the medical record that may lead to confusion in the care of the patient, and also maybe fodder for lawyers down the road. So, if you can get everyone together, since not everybody has the same perspective of what happened, making sure that everybody shared what happened will improve everybody's accuracy in their documentation. You want to do it in a safe space where the participants feel comfortable enough to express their opinions and offer suggestions without distractions. You're explaining to the team that you want to help identify opportunities for improvement in teamwork skills and outcomes, and you want to also provide for everybody's emotional well-being, particularly in some of the more emotionally difficult events. There is training out there for debriefers, and there are debriefing guides, and I recommend them, but it shouldn't prevent you from starting to do this. Next slide. So some of the triggers that we use are clearly after something like a maternal death, but maybe an unplanned hysterectomy, an unanticipated admission to an ICU. We do it for unanticipated fetal or neonatal deaths or significant neonatal injury. We also do it whenever a member of the team thinks it would be useful. And we do it for significant postpartum hemorrhages. We may do it after patients, who've had an eclamptic seizure. I mean, you can create this list however you want, and I think it's a really good idea to have automatic triggers and to really get in the habit of doing this. We've done them after shoulder dystocias. We've done them after emergency cesareans. You just need to think about what works for your unit. Next. There are some tools out there. This is a freely available form that you can download from the California Maternal Quality Care Collaborative website, CMQCC. This is their form. I'm not going to go into too much detail about it, just want you to know that it exists. Next slide. Nope, next. This is the form that we use, and I'll go through it in a little bit more detail. We contributed to a publication that appeared in the Green Journal in 2014, and this is the form that largely we continue to use today. It's reproduced in that publication so you can get it. I stole it from and modified it from things that I found on the internet when we created it. Next slide. So going through this form, what we do, this is what's in one of the boxes. We start with identifying what went well, and we're focusing on things like communication, role clarity, did people know what their jobs were as we dealt with the event, how well did we function as a team, are there situational awareness issues that went well, how did we do well in the decision making, so we identify what went well, and when we do this, we go around the room. I always start when I'm conducting a debriefing with the person who's sort of the person lowest in the hierarchy, because once we get up to someone who's at the top of the hierarchy, at the top of the totem pole, the people lower down are going to be afraid to say anything that contradicts. So you really want to get their opinions first, so that they're not, if they want to say something didn't go well, you don't want someone later on to have said that went well when really it didn't go well. And then next slide. Then we look for opportunities for improvement, and very much we say opportunities for improvement, and we don't try not to spin it negatively, like by saying what didn't go well. We say what went. Where are opportunities for improvement? Could we have done better? And these are focusing on human factors because we're going to have something around systems issues next. So, could we do better in our communication? What were the barriers? Can we do better? And again, these are all team steps concepts: role clarity, teamwork, situational awareness, decision making, where there are human errors. Next slide. And then finally, we're looking for systems issues, or there are equipment issues, where there are issues with medications or blood products, inadequate support in the unit or other areas of the hospital, transport issues, staffing issues, anything else that we come up with are recorded here. Next slide. And then, we also have to make sure that if there are systems issues identified, that someone is assigned to follow up on them and report back to the team. So we're looking for real-time identification of opportunities for improvement in teamwork, knowledge, skills, and systems. We want team members to feel empowered, supported, and heard. And these debriefings also become an opportunity to identify potential second victims. And I have to say, in the middle of the night, if it's my event, I may lead the team debriefing. If there's another attending physician around, I may ask one of them to do it. Our charge nurse will feel comfortable leading a debriefing. I've sometimes been called in after particularly difficult events, like we had a maternal death about a year ago. I came in to do that debriefing even though I had nothing to do with the care of that particular patient, but it was better to have someone who was remote from the event to lead the debriefing. So you need to think about those kind of things. Next. So emotional debriefing is, you need to think about this debriefing, which both has an aspect to it which is concretely about the care of the patient, but it also may raise issues that require emotional support for the individuals involved. And so we've also done separate debriefings where we just focus on the emotions after particularly challenging events. So these are intended to mitigate the impact of a traumatic event, facilitate the recovery of individuals having normal reactions, restore their adaptive functioning, and identify individuals who might benefit from additional support services. This may take precedence, if you have something like a maternal death, this may take precedence over the fact-finding debriefing because you've got to deal with that or you're not going to get anywhere with the fact-finding debriefing. Next. So a question I often get are, what are these legally protected? And I'm going to tell you that there are actually variations in state laws which make it difficult for me to answer that question. I can tell you that we've been instructed by our risk managers that these are protected. And I'll tell you that the form that we use, that debriefing form, does not have any patient identifiers on it. We may collect systems information on there, but we're looking at that data in aggregate. We don't put on that form the individual, anything that could identify the patient. We don't put down details of the event. That's for your QI process or, for charting in the patient's medical record. We're strictly speaking around how the team functioned, that blood bank responded really well, or blood bank didn't respond as quickly as it should have, and I need to follow up on that kind of a thing. But we don't put patient identifiers on that form, so it has no value to the lawyers. And we've been told that's okay. This is just a tool, like your scissors are a tool. You want to double check that you do have the protections you need to do this. Our hospital has said, we're more concerned about the next case, and if the debriefing is going to prevent the next case from happening, we'll take the risk on the current case, and we want you to debrief. So You need to collaborate and coordinate with within the existing structures around quality and patient safety that you have at your institution, and work closely with your legal and risk management folks. Next slide. So some final thoughts. I think that debriefing has the potential to really transform the way teams function, the way systems issues are identified and corrected, and therefore improve the care for our future patients and for our well-being as providers. It's low cost and low resource. The tools exist, and it just, is a question of changing your culture so that you can get it done. And it provides valuable data. So I think it's something that everybody should be doing, and probably should be doing more often than we are. Next. With that, I'll finish and be happy to, if time permits, to answer some questions that you might have. And if you have my slides, there are some references to the articles that I mentioned.